when we look at patients as a whole that have critical limb ischemia or chronic limb-threatening ischemia, we do see that data that has come out of Dartmouth using Medicare shows that amputation rates are decreasing. When we look at individual locations and small places, or break it down sometimes by state, or even breaking it down by region, there are certain geographic areas where we still see high levels of amputation rates. And some of those are located in the South, and a lot of those are located in regions where they may not have vascular specialists. In addition, when we're looking at some of the sickest patients who don't necessarily have good access to healthcare, those that maybe go through an inpatient setting or an emergency room, those patients may have an increased risk of amputation, but overall, we see a decrease. The disparities that we see in my research, I believe, is truly access-based. When we adjusted for things like race and gender and multiple other comorbidities, what we found is that we didn't have racial differences. But the reason we didn't have racial differences is because we adjusted for access. We had a variable in our data set that looked at how often patients went through the emergency room or were admitted to the hospital. And that is an indicator of access. When you adjust for those factors, you can see that the racial differences go away. And I think that's something that's really unique. A lot of data has shown that there are racial differences, and I do believe in those. But I think we have to move beyond just seeing the big scope of there are a difference between Hispanics and Blacks and Asian populations, and seeing what is it underneath that. And that really comes down to access. It also comes down to health literacy and trust in the health system. The main factors that predict whether or not somebody is going to get an amputation when they have arterial disease or diabetes is really so many kind of social determinants of health. Do they have health insurance? Do they have consistent health insurance? Do they have time to go to preventive care visits? Are they getting appropriate preventive care measures? And then are they being educated about what some of these things mean? When you look at how we educate people in general about health conditions, arterial disease, diabetes, it can be overwhelming. And I think we have to simplify and break it down. We also have to help people understand that going to the doctor doesn't need to be a reactive thing. It should be a proactive thing to make sure that you're on the pathway to health. And unfortunately, in the United States, where healthcare can be very fragmented because it's based on whether or not they have a job that provides healthcare frequently, I think we see a lot of people that fall through the cracks in that area. When I think about what are the solutions and what tools can help us, I actually become a little overwhelmed, because I think that in the United States, it takes revamping healthcare completely. But I do think we need to provide at least a basic level of healthcare for people so that they can understand when they have these conditions such as arterial disease, how to get appropriate treatment and how to take care of themselves, how to get to see the appropriate specialist to get proper foot care. Also helping them understand what it is that they can do individually. But I believe, unfortunately, in our area, healthcare is really patient-driven. And so it also means creating communities of education. So within the community where these patients live, be it rural or urban, creating centers where people are walking together maybe, or eating healthy together, or farmers markets that come to areas where there are not large grocery store chains to bring in fresh fruits and vegetables. There are multiple different things that we have to do, but a lot of it is very simple, and getting back to what it just means to live a healthy lifestyle.